an important document which really was what we call a game changer in the UK, and you can access it if you're looking at development of your own services. It helps the commissioners, in other words the people buying the service, and the providers, the people like me delivering the service, to develop minimum standards for community eating disorders. One of which is what they call the access and waiting time standard, that if you're referred, you should be seen quickly. It puts pressure on all of us to improve our services. So to get the money that we were given, but to deliver a service which is fit for purpose. So we're obliged to see our patients within 1 week of an urgent referral and within 4 weeks of a non-urgent referral. And in fact, our money will depend on us delivering these standards. So, let me tell you now about where I'm from and where we fit in. I live and work in a place called Solihull in England. It's in the heart of England, it's in the centre of England, about an hour north of London. It's got a population of just over 200,000 people, and we've got about 50,000 children, 0 to 19. It's one of the richest places in England to live, in the south of Solihull, but in the north it's one of the most deprived areas of the country. So it's a place of real contrasts. And this is where I work, and this is where my service developed. So this is the story. I went from London to Solihull in April of 2006, and I developed another team called the Intensive Community Outreach Service. We called it ICOS. And that had a brief to manage all young people with severe mental illness in Solihull, in the community, instead of in hospital. So if you had schizophrenia, depression, severe OCD, or you were suicidal, my team was given the job of managing you as a hospital at home. And we had a different mix of early intervention, assertive outreach, home treatment. We were a small multidisciplinary team with a very small caseload, like a virtual ward in the community, about maybe 13 patients, 14 patients. And we managed to reduce hospital admissions by half. We reduced the length of stay by a third, where young people were admitted. And we won a lot of awards, actually, so I can tell you this without being immodest. We were the Royal College of Psychiatry Team of the Year in 2014 because we became an example of excellence, and we had a lot of people visiting us to use the model. And we saved so much money in avoiding the hospital that we paid for ourselves each year. We didn't actually cost anything to the NHS. So that sounds great, doesn't it? But unfortunately, well, let me tell you a bit more. Because of where we were in Solihull, during this period, about half of our patients had eating disorders. And anorexia is the one most at risk of being hospitalised. So we developed a kind of de facto expertise. I didn't really know anything about eating disorders, but I developed that knowledge as we went along. So we recruited a dietitian, and we began an intensive home refeeding program during that time. Now, in 2016, there was a service redesign, and somebody said, "You're such a good team, we would like you to do some more things. We would like you to do overdoses, crisis intervention, out-of-hours services." And we went through a lot of change, and our effectiveness was diluted. We couldn't do all of the things that we were being asked. But at that time, the change coincided with what I was telling you about the commissioning initiatives to develop specialist services. So somebody came along and said, "Can you make a specialist eating disorder pathway and develop a specialist eating disorder service?" And we said, yes, please. We dropped the suicide, we dropped schizophrenia and psychosis, and we focused exclusively on eating disorders. And we went to a national training program, which is 9 days of residential training provided to everyone in the country. And I have the details, if you like, because all the resources are on an online portal that you can access. The videos, the training, the lectures. And the idea was to equip the team in the community with the specialist know-how to manage eating disorders, and to have a philosophy of ongoing learning, to bring in routine outcome measures, and to use best evidence to provide standardized treatments, and to roll that out across the whole country to improve quality of care. So that's what we did. My old ICOS team went to that training, and we came out as the Eating Disorder Service. So the acronym, we're called TEDS. So who are we? I'm a consultant psychiatrist. I have a team manager who is a clinical nurse specialist, a nurse, a community support worker who is a nurse practitioner. She's not qualified. We have trained her now as a phlebotomist, so she can do the bloods for our eating disorder patients. We have a family therapist, a psychologist, a dietitian, and an administrator who helps us to run the show. This is our referral form. I'm not expecting you to read it, but I put it there to tell you that we take referrals from dietitians, paediatricians, gastroenterologists, general practitioners, but also people you wouldn't think, the school nurse, the dentist, the teacher, the parent, and even the young person. They can self-refer. They go online, they put the details, and we get the referral. It comes to what we call a single point of access. And if there's anything in that information which says eating difficulty, it comes to us. And we look at it the same day. So we take 0 to 19, but most commonly probably the teenagers, but we often see 8, 9, 10-year-olds with difficulties in eating disorders. So at this point, unless you have any questions, the easiest way to tell you what we do is to take you through a real case, which I hope will bring it to life. I saw her in clinic last week, and her parents have given me permission to share her story with you, and hopefully I can take you through that, unless there's any immediate question about what I've said already.
How the parents and doctors in different regions know about this, and what the red flags are not this?
How do they know?
Yes.
We have a website, so anyone who wants to Google the difficulty for their local area will be directed to our service. And it says, if you're worried about yourself or your child, fill in these details and send us the information. And it goes to a single point where a clinical team does a kind of a triage, and they contact the family. If it's not, it might be for depression or anxiety or some other problem. So depending on what the problem is, they have something called a choice appointment. They meet somebody who decides, do you really have a problem, or can you go to a charity, or do you go to your school, or do you need a doctor? But if there's an eating problem in this information, it comes to me. So, now I'm not expecting you to read this, but this was the parent. So this is the form, and the parent has written this information. And a mother knows her child best. So I'm going to see if I can read out to you a little bit of what she says. I'm not going to read out all of it, but it tells you what the problem was, okay? So she said, my daughter is struggling with intense anxiety, which is impacting on her ability to enjoy life, school, friendships and activities. She's currently particularly worried about eating because she's frightened of this making her ill, but more recently because it might make her put on weight. She's always been quite fixated by the need to be healthy and worried that certain food could make her sick. But now she's struggling to justify eating any meal. She's trying to skip meals and drastically reduce her intake. School have noticed this and that she appears very thin. And the mother has written here from the doctor, BMI currently 14.35. And she goes on to say she's always worried and had particular rituals or requirements. This was even the case before she started school. She had certain things that she had to do to her socks and clothes, and she couldn't deviate. Now she has lots of safety behaviours and rituals she must follow, and her anxiety is significantly worse. She's constantly moving and her stress is visible. She has a short fuse, and this is impacting on her brother at home too. Perfectly described by the mother. She goes on to say, her current fixation is food, but she's also extremely anxious about germs and the potential of getting sick. She needs to wash her hands very frequently, and she can't touch food with a hand that has touched anything else. She has systems for managing this, such as how to hold her sandwich, but she's completely inflexible, causing her to panic and experience terrible distress when challenges occur. She's become a much quieter child recently, and this is noticed at home and at school. She has few friends and seems to be struggling to connect with children her age. So again, beautifully described. So the mother filled this in, sent it to us. So these are her initials. She was 11 when we saw her. We saw her last July, and she was screened, and the information was sent to my team. And we saw the information on the 5th of July. My nurse picked up the phone to the dad. What's the problem? He was very distressed. He said, we've got huge concerns. Our daughter is eating 500 to 600 calories a day. She hasn't gained weight in 1 year. And he said, it's much worse than when my wife filled in the form, because last weekend her father died, and we're all really in crisis. Please help us. So we called them in straight away. I think there was a weekend, and they came on the 9th of July. Before the funeral of the grandfather, the family came to our clinic. So on assessment, this child weighed less than 30 kilograms. She had a BMI of 13.1. Don't know if you remember, but our diagnostic cutoff is 17.5. So obviously very low BMI. Are you aware of percentage median BMI? Is this something that you use? Because this is something new for us in the UK. What we do is...
Because in this age,
Exactly.
you use body mass index per age.
Exactly.
WHO curve.
Exactly.
Not only body mass index.
Exactly.
You calculate body mass index and spot
On the centiles, yes. So in adults, we use BMI, the relationship between height and weight, and as you rightly say, in children, we take account of age and gender. We plot it on the 50th centile, and the median is 100% BMI, okay? So if you go below that, we call 95% minimum healthy weight. 85% is the diagnostic cutoff for an eating disorder. 75% you're beginning to think maybe this child needs to be in the hospital. This child was 74%. So she was never a big child, but she's lost 25% of her body weight. Now, I've had patients who've been 66%, and the lowest I've ever seen, which was in the hospital, was 48%. So that would be a normal child losing half their body weight, a living skeleton. I've never seen a a worse case. But this child was 74%. She was hypotensive, she was bradycardic, and we sent her straight to the accident and emergency, to the paediatric assessment unit. BCH is the Birmingham Children's Hospital. So there she had bloods. So we had for blood count and use and ease, phosphate, magnesium, calcium. We can go through those in detail if you like. We do vitamin estimations and so on. She had an ECG, because obviously that can be an issue. She had vitamins prescribed, and this is prophylactic as well for refeeding. You'll be familiar with refeeding syndrome. So refeeding syndrome is rare, but the risks of it increase if somebody's had very rapid weight loss, if they have very low BMI, if they've had very severe restriction of calories, if they've got a low white cell count or a low phosphate, the risk increases. And this child, obviously she had severe dietary restriction. She was low BMI, so it's potentially a medical emergency, at least to begin with. So we prescribe thiamine and we prescribe multivitamins straight away to cover refeeding. So then we said, no school, and you can't even go upstairs. You have to stay home, you can't go up and down the stairs, you have to sit on the sofa in front of the TV with your mum and dad looking after you. You're grounded. And then we do a menu. So we go through the food diary with the family. What did you have yesterday? What do you have on an average day? This child, the day before she came to us, she had 2 slices of melon and 600 mils of water. So we now say, okay, food is your prescription, and we write it down. You have to have 3 meals and 3 snacks, and you start on a quarter portion of normal, half portion, and then full portion. And we give them 20 calories per kilogram per day, and every day we increase by about 200 calories. We can't give them the whole thing straight away because of the risk of refeeding syndrome.
Follow-up by investigation for post-hospitalization.
Yes, yeah. So our nurse went home with the family. She opened the cupboards. She had a look at what food was there. She opened the fridge. The dad said, I bought some yogurts for you. Where are they? And the little girl said, I hid them in the garden. She was so reluctant to eat, and the nurse went in and got out the bowls that they're using and the cups to help the parents to measure a quarter, a half, a whole portion. And also to have a look if there was any diet food there, skimmed milk instead of whole milk, and so on. Now, this is interesting because it's the EDEQ for children. I don't know if you're aware of it. I'm not expecting you to read it, but it's a routine outcome measure. We apply it at the start of treatment, at 6 months, and at discharge, and it quantifies the severity of eating disorder symptoms. I put it up there because the ones that are circled most by this girl, I'll read them out to you. She says, maximum score, have you tried to keep to any strict rules about eating to control your shape or weight? For example, a calorie limit, a set amount of food, or rules about what you can and can't eat. Has thinking about food or calories made it much harder to concentrate on things you're interested in? For example, reading, watching TV, or doing your homework? And she's put 6, yes. And on the other side, I think she's written, have there been times when you felt that you lost control and felt you ate too much, but did not eat a very large amount of food given the situation? And she circled yes. How many times has this happened over the past 2 weeks? She's written all the time, all the time. Complete torture these symptoms are for these children. So she filled this in, and her parents also filled one in as well. So I was talking about the nurse going to the house. So we go to the house every day, if we have to, and we bring our own food, and we sit with the family, and they all eat together. And what we're doing when we sit with them is we're observing the dynamic between the child and the parent. We're having a look as part of our assessment at what the problem is. Are they cutting the food very small? Or are they dropping it? Or are they smearing it under the table? Or are they making it into crumbs so that they don't have to eat all of it? All of those behaviours. Are they chewing very, very slowly? Are they taking a long time to eat? So our nurse is modelling normal eating behaviour. So we're chatting and eating. She's setting the pace so that you're expected to catch up with the nurse and eat your sandwich at the same sort of time. And you're modelling the intervention for the parent. So you might say, please finish that, or you can manage that, or if the child can't start, you might say, come on, you can do it. And the parent is watching the nurse support the child so that eventually the parent can take control of the eating around the table. And obviously we can also see how much they're complying. So that's very important. You remember she came on the 9th or 10th of July. The following week she saw our specialist dietitian. So we have a specialist eating disorder dietitian that does a scientific analysis of energy and nutritional requirements and designs the prescription of the food in the menu plan. My nurses can do it, I can do it, but the dietitian does the dairy, the vitamins, the minerals, all of it properly designed. And it gives us a lot of credibility with the young person, because we say, look, it's not what I think, the specialist has done a scientific analysis of what you need, this is what you need, there's no choice, this is your prescription. Now I've mentioned medication there because, how are we doing for time? We're okay. There is no medication, as I think you probably know, for an eating disorder. And obviously when we see young people who are malnourished, they're flat, they're low, they're rigid, they look quite autistic. I mean, they may be autistic, but they look very flat. And with weight restoration, their mood improves spontaneously. You don't need to do anything, you just have to feed them. However, there is sometimes comorbidity. So you feed them and they're still very low, very sad, very depressed, very anxious. Or when you take the history, they were very low, very anxious before the eating problem. So there is the necessity to consider a pharmacological intervention. So this girl, you remember her mum said, she's always been anxious, she's always had worries about the germs and anxiety and the rituals. So in her case, I thought it was important to also prescribe. So we use two main categories of drugs, the SSRIs, which are licensed for use in children, and the other one that there's no hard evidence for this, but in clinical practice in the UK over the last 3 or 4 years, we've been using very, very small doses of olanzapine. And it works very well for distress and emotional arousal, but also most of these children, and it does help with weight gain, but not in the anorexics, but maybe in the ARFIDs, it does increase the appetite. In anorexia, it doesn't, because the wiring of appetite regulation and response to hunger is disrupted in anorexia. So I always say to my anorexic patients, you will gain weight under my care, but not because of the olanzapine, because of the refeeding. The olanzapine will help you with your anxiety.
I met a patient like this, but the issue is that she used to Google all the medicines.
Exactly.
This is one issue. Even the vitamins.
Yes.
She's following and tracing.
Yes.
And she refuses to get any form of intervention that
Correct.
is considered to be complementary, dietary, or medication.
You're right. I mean, for example, if you're prescribing a liquid, they want to know if it has calories.
Yes.
Does the capsule contain something which might have a calorie? If you're prescribing an ointment for their skin, they're worried about the fat from the ointment or the cream going into their skin and leading to weight gain. So they're very rigid. And of course, if they Google olanzapine, they will see that children gain weight on olanzapine. I always say to them, I'm going to tell you the truth. The truth is that psychotic young people do gain weight. A significant proportion of them gain weight. But in our clinical experience, anorexic young people do not gain weight on olanzapine. So I say to them, you will gain weight, but because of our program, not because of the medicine. And that's the truth, otherwise they would never consent. And we do manage to persuade them. And once they start the olanzapine, they're hugely benefited. Actually, many of them don't want to stop the olanzapine because it's given them so much relief. And one of the things I didn't know is that anorexia has a voice. So a lot of them report an anorexic voice. It's shouting, it's whispering, it's mean, it's telling them bad things. And although it's not a psychotic symptom, it's not a hallucination, the intensity of the distress with that voice diminishes with something like olanzapine. Does that make sense? So if you can persuade your patients, it is useful. The other things I haven't put here, but we have, when we sit with the patients and help them eat, we would give them cue cards, so things that they laminate to remind them of encouragement to eat. And then afterwards the nurse will play a game with the child so that they don't feel that distress after they've eaten. And also that they sit, that they don't go to the bathroom in case they're going to vomit. So we sit with the child for half an hour, we play cards or a game. We manage the distress and the distress tolerance, and we ensure that they're not purging. And also we give them time limit. You have 1 hour for your meal and 30 minutes for your snack. I mean, I've seen children take 1 hour to eat an apple, very, very slowly. And we say, no, you've got this meal, you've got to have it in this length of time.
But you put a cut-off point for the time. Because if you need more than 4 or 5 hours in eating,
We cut off. Yes, exactly. So if they can't manage that, we say to them, you have to have what you haven't eaten as a replacement in a nutritional supplement. And sometimes we say to them, if you can't finish it, we will double the calorie content of what you've got left, and you have to drink that.
Yes.
But obviously, in the inpatient setting, of course, we go to nasogastric feeding.
But what about something? I feel as if when you do this at home, there is a form of yielding or acceptance. Because with this patient particularly, because I just remembered it, the issue is that she prefers staying at the hospital.
Yeah.
And to be managed by a nutrition, and the role of the psychiatrist has to be something else apart. We should not admit or talk about her anorexic problem.
Yeah.
And she was usually preoccupied with the snacks, though she never. I've been with her 4 or 5 months. Over the 5 months, I feel that she is not losing weight, but at least she's not gaining. This means that the nutritionist schedule even is not adding on anything. And she's always skipping. When I started to enforce at least the schedule that we have been agreed upon, then she has to skip the other way around because she has to consult first the nutritionist. So she's very manipulative.
Very manipulative,
Very
yes,
manipulative.
yes, yeah.
But to me, it's very hard even to think that they will accept, because we are at home, the environment itself, which is receiving this service at home, makes that difference.
Well, there's lots of elements to this in different ways. Sometimes the parents say, your nurse came in, and I've been trying to do this for months, and my child hasn't been doing it, and your nurse has come, and she's eaten her meal. So it's a kind of figure of authority that comes in, takes immediate control, And we all have children, you know, our children who listen to their teacher but don't listen to their mother. So there's that element. The other element is, as you say, a child who doesn't want to go to hospital knows that the only option is to cooperate with this program. If you don't cooperate with this program, you have to go to hospital. The other way is some children want to go to hospital. They're desperate and their parents are desperate. And in that case, I will tell you more about the decision to admit. We do take them to hospital. This doesn't work for everybody. But there are different elements to this cooperation. You think they're never going to cooperate, and by magic, they do.
She asked for hospital admission after, for example, severe hypotension.
Yes,
And then she loses consciousness, so they have to move her to the hospital.
exactly.
So it's because of metabolic
Indeed.
situation, that's it.
And that's what brings me in her story, this girl. I can call her by her first name because her name is Lila. So we started to think about hospital for Lila because my nurse was going in and she was eating. You can't be there all the time, and her parents were really struggling. She was still hypotensive and she started to restrict her fluids. And we said, we think we might not be able to manage you at home. We're going to refer you to the hospital. So she went to the hospital with her family. She had a look round. She had an interview and a mental state examination. And they said, we can admit you, but we don't have a bed available until August. And this is very common in the UK. We don't have enough beds. So what happened? This, you can't read it properly, but it's on my slides if you take my presentation. This is a risk template. It's adapted from something called the marzipan. Have you heard of the marzipan? The management of really sick patients with anorexia nervosa. Marzipan, do you have it in Egypt? It's almond paste that they make sweet.
You know the other marzipan.
Okay. So there's red, amber, green and blue. So depending on your weight, your fluid intake, your calories, you have this traffic light system and you can decide if your patient is at risk. So we decided on the traffic lights she was at risk and we sent her there. And as I said, she was offered a bed in August. But what happened was that she did exactly what we said. I'll go back a step actually, I don't want to distract you. She did exactly what we were saying. She didn't want to go. She saw it, she saw the other children away from their parents. And she said in her own words, she dug very deep, she said, inside herself to cooperate. And she did. And it worked really well that she knew that she had to avoid an admission. And she was able to turn it around through support from us without going to the hospital. Even though by then she was 72% BMI, which according to this was very borderline for an admission. But obviously if the parents are exhausted or if physically compromised or failing to stabilise the weight, you admit them. So what happened? We refed her through the summer. And we did various things. So I'll give you, this is where, this is what my team does. We have a parent support group. So every week, for 6 weeks, the parents come and we do teaching for them. So we give them information on eating disorders, on understanding their child's behaviour, on how they communicate, on how they plan meals. And they come every week and they sit together. It's manualised. I can give you the manual if you like, with all the materials that we share with the parents. And they sit together with other parents, and they're all at different stages. So they help each other. So there'll be a parent there who says, well, my daughter was really ill, like Lila, and she did this, and she's better. And they have hope, they have emotional support, and they have education from each other. So sometimes we just sit there and they're talking to each other, and it's very, very powerful and very emotional. And the other thing we do is I meet the parents one-to-one as a psychiatrist to understand their own psychopathology because sometimes they have a history of eating disorder, or they have something relevant like alcohol abuse or depression, which has impacted on the family system. So we do that as well. And the emphasis of treatment is, for the child, is stabilization of weight, stop them losing, and then weight restoration, get them up to a minimum healthy weight, and then weight maintenance. What's it like to live and move and go to school at a healthy, minimum healthy weight? Does that make sense? So there's 3 phases of treatment. And our CBT, our psychological and talking therapy, begins with weight restoration, because when they're malnourished, they're not able to benefit from CBT. They're not concentrating, they're not retaining information, and so on. Does that make sense? Yeah. Is there a problem? Are you happy with the time? And it's fine? Yeah. So I'll just tell you a bit about the CBT. The NICE guidance is for what we call CBT-E, CBT enhanced. So it was developed from CBT for bulimia nervosa, and it's got the same elements. You look at the distorted thinking style, you look at over-evaluation of weight and shape, control and dieting. But it's not enough. The CBT bulimia program had lots of people who failed to respond, and it was enhanced and developed, and it's become transdiagnostic, and we use it in anorexia. So now we include other elements in the psychology of clinical perfectionism, which Lila is a total perfectionist, and that's where the control comes in, and setting impossible standards. Mood intolerance, low self-esteem, and interpersonal difficulties. So all of these things come into the CBT, which they have with our psychologist. And it's a minimum of 16 sessions over 16 weeks. And the other element of it is family therapy. There are different models and manuals for family therapy. There's something called the Maudsley family therapy model that you might be aware of, developed by Lagrange and Locke, which says 3 phases. The first is total parental control of eating. So what I was telling you about the nurse going in, just take over completely. The second phase is to give back some autonomy to the child for their eating. And the third is full independence and the child catching up on their development and their identity. So that's in recovery. You consolidate. But it starts by saying all parents were feeding their children, so what's gone wrong? We're going to support the family to feed their child again. And we're going to do that without blame and by looking at the family as a system. We're not going to say, you are the patient, you need to be fixed. We're going to look at the whole system and how it operates, including the siblings. So that's how it works. Now, I'm coming almost to the end actually, but I wanted to show you the real example of Lila and what she was doing with the psychologist, because it's very nice. She's a clever girl. So you can see from there, she was asked to think about her illness, and she called her illness, we're encouraging the child to externalize. So they don't think that they're the illness has taken a hold of them. And she called her illness ED, ED, eating disorder, but Ed, like Edward. And she said, he's a boy, and he's mean and nasty. And I'm going to beat Ed. And she said, I'm going to beat Ed by putting Ed to bed. So that was her slogan. And our psychologist went with her and said, okay, what are the good things about Ed? He makes sure I don't eat too much. He makes me feel good if I haven't eaten. He makes sure I don't get overweight. And he makes me feel like it's a good thing to lose weight. Okay, what are the bad things? He makes me very ill. He lies to me. He makes me and my family stressed. He bullies me. I have to go to the clinic. He has spoiled my summer. You remember it was July, their holidays and everything were cancelled. He stopped me from going to school, and he might stop me starting senior school. So you help the child to sort of weigh up the advantages and disadvantages of their disorder. So he used to make me hate meal times. He makes me feel guilty, and he takes away my energy. And then she was asked, how do I keep him as an enemy? Trust my mum and dad and Ted's, we're Ted's, the team. Eat the food that I need to eat. Take the medication. Find ways to distract myself. And remind myself of all the nice things that can happen if Ed stays an enemy. And that's the beginning of the CBT approach to combating the disorder, which goes hand in hand with weight restoration. Does that make sense? Now this is a timeline. I almost done actually, but this is in the handwriting of the psychologist. Maybe you can't read it, but it's very nice because it gives a really typical picture of the gradual onset of the disorder. So it says at the beginning, year 5, she says, my friend had lots of problems. I had low confidence. She was very controlling. She sent horrible, I don't know what she sent, but it was horrible. But stress, bullying, transition, the prospect of puberty, all of that plays into the prodrome of the illness. And then as the year goes on, year 5, it says worries about heart disease. What she started to do was she cut out dairy because she got worried that there would be fat around her heart and she would get ill. And then as you can see from there, she became pescatarian. She cut out meat and she would only eat fish. And then later on, started to restrict the amount of sugar I had, she said. And then started to restrict the amount of food I had, and she realized she became depressed and anxious. And finally on the line, my teacher started to notice I looked ill, and I missed learning, and I got very ill.
This is for the same baby, right?
The same child.
This is a long time.
It's a long time, yes. It is a long time. But what happens is at the beginning, the parents don't notice. Because sometimes parents say, how did I let my child go this ill? Sometimes, for example, if the child stops chocolate, crisps, junk food, the parent thinks that's great. And these sensitive, sometimes autistic children, they take healthy eating lessons very seriously. The teacher told us not to have too much sugar. And they take it in a very concrete, black and white way. And they cut it out and they cut it out. And it happens gradually. And obviously, eventually, sometimes parents say, I didn't notice, and then suddenly my child went on holiday, went to the swimming pool, took off her jumper, and I thought, she's lost so much weight, what's going on? So it happens gradually, and the parents might not notice. It's very interesting. Right. So this is what happened to her. In July, when she came, she was 74.7%, as you can see. By September, she was 81.6%, and she'd grown a little bit. Okay? And by the end of this year, just a few months ago, she was 97.3%, so she was above the minimum healthy weight. She'd grown very significantly, and she's absolutely thriving. I saw her in clinic last week. She was a very happy girl. She's back in school. She's doing really well. Her perfectionism is a problem. She's obsessed with getting her homework right. So in some respects, we've dealt with the eating, and her perfectionism is showing in other anxieties. But she's still seeing the psychologist. And you remember her grandfather died. Now, she didn't grieve for that grandfather because she was so ill that she was emotionally numb, shut down. She started to grieve for the grandfather. And the psychologist is taking her through that process and helping her mother with that grief as well. So we have great outcomes. We have a high degree of user satisfaction. And usually we can discharge our patients back to their GP. or they go to university and we say goodbye and good luck, or the proportion that don't recover, we transition to adult services, age 19. I hope this girl we can discharge back to the GP. Now finally, these girls, their mother put the story in the newspaper, so I can use their photograph and respect their confidentiality because it was in the newspaper. They're sisters. So the older sister, obviously you can see, has anorexia. That's what about 70% median BMI looks like. And that's her little sister, who's a normal child. Now unfortunately what happened was, the little sister developed anorexia. She became my patient, and I ended up having to treat her in the hospital. So these two sisters developed anorexia, one after the other. And the older one wasn't my patient, but the younger one was. And the final picture is them fully recovered. And that's their mum. And they're running a charity marathon for BEAT, which is the eating disorder charity and information service in the UK, and they're fundraising for them. So it's had a happy outcome, and I thought I would end with that story. So I'm happy to take questions. I'm happy to talk about inpatient program if you like, or to answer any other questions or comments that you have. I hope it's been obviously interesting and valuable for you.
These two girls,
Yeah.
the cause is genetic susceptibility, or maybe the situation in home, or not so.
Very good question. We don't know, do we? We know it's multifactorial. We know there's a genetic predisposition. We know that you might have a genetic predisposition and not develop the disorder, but you might then have environmental factors which act upon that predisposition. And then you might have a family history of an eating disorder, say in your mother. That mother had an eating disorder, but is that genetic or is it environmental? Is it the way she fed them? Is it the messages that she gave them about eating disorders? Is it the way she fed them when they were little? So it's multifactorial. And then there are precipitants like stress or anxiety or transition. And then there are maintaining factors like conflict in the family or whatever. So it is multifactorial. I didn't mention, I should say that the ones who end up in hospital are the more complicated ones. And they're often comorbid autism. And they're a real challenge in the inpatient setting because sometimes over-control and nasogastric feeding of the very unwell comorbid autistic children can make things worse. So autism and anorexia coming together is a really complicated area. And of course, there's the differential diagnosis, because sometimes you're anorexic and you look autistic, but you're not. And sometimes you're autistic and you look anorexic, but you're not.
Because many of the autistic are picky eaters, and sometimes
Yes, picky eaters, yes.
We can elicit this is very early.
Yes, very early.
In complementary feeding.
Yes,
Failure to upgrade from one texture to another.
exactly.
Resist.
Yes,
This is very early.
it is. Now they are now properly called ARFID, Avoidant Restrictive Food Intake Disorder. So they have a sensory issue with food, with weaning, with what we call food hierarchies. They can't move from one food group to the other. And our dietitian does something called, and our psychologist does food chaining. So you do something very small, you change something very small, and then that helps them make the next step. It might even be things like the colours, or the food touching, or the textures. So all of that is part of what we do, but we're developing that expertise because it's new, that the understanding of ARFID is new.
Excuse me.
Yes.
You mentioned that at the beginning of the intervention, you directly go to the child at home,
Yes.
and then you start to interview.
Yes.
Do you use these forms of behavior therapy? You mentioned they have a problem with the
Yes.
sensations, the smell, the touch of the food, the amount, sometimes they are afraid of the color, of the texture, and so on. In this case, you make like a form of desensitization. And the
Yes.
schedule we do is a form of gradual desensitization.
Yes.
Do we give them a chance to choose the elements they like?
It depends. It's a very good question. In anorexia, we don't give them any choice. We insist that they have no choice. And I digress slightly, but the anorexic child will be in the kitchen saying to mum, don't do this, don't put that in there, cook this especially for me. So we say, out of the kitchen, mum is going to make you what you need to eat, she's going to put it on your plate, you have to eat it. Now with the ARFID, they're not being driven by anorexic cognitions and the desire to lose weight. They're not driven by a need to restrict, to lose weight. So we can be a little bit more flexible with what we allow them to eat. And we accept that if you're such a child, you may grow up and still have a very restricted diet. And you can live and function, but you're never going to love food, you're not going to, you know, we all experience it as a pleasure. Those children will grow up and not experience it as a pleasure. So we work within their limitations. I'm not expecting a child with ARFID to eat, you know, to eat roast beef or to eat strawberry ice cream or to eat biscuits if they don't like the...
Not all people respond with food.
Exactly.
Some new imaging.
Exactly. So as long as it's nutritionally balanced and we use those techniques of chaining or the hierarchy, we're simply trying to get them to eat an adequate diet to fuel growth. And that's it. And sometimes I say to them, I was listening to the radio and I heard a presenter of the radio say he's eaten the same evening meal every day of his life for years. I mean, to me that sounds terrible. But for him, he's alive, he's functioning, and, you know, maybe we aim for that.
There is a new imaging technique now for this case, and one of our colleagues working in America said that some people who like food, the imaging shows that there is a feel of happiness,
Yes.
and the other have no
Nothing.
imaging and
Yeah.
no activity at all.
Exactly. Yeah. If you don't remind them, they don't feel hungry. They don't seek food. And of course that causes so much conflict in the family or with the siblings or at school.
So the psychotherapeutic intervention may be behavioral techniques depending on the different stage
Yes.
of the therapeutic process. We start by scheduling, introduction of the food that is imposed on them, and we get how many times, by the way, like the complementary, we have to expose, for example, the nutritionist mentioned that we have to expose the child for more than for the same
Yes.
kind of food over a
Yeah.
time,
Yeah.
around 10 times.
Yeah.
Food girls.
Yeah.
Food girls.
Yes, that's right. Yeah.
So it's the same for them. We have to, this schedule, we can expose them for this schedule for a long time, as a brief, and we can change this.
Yes, well, again, it depends on your diagnosis. You know, you have to make an accurate diagnosis before you can put in the correct interventions. So ARFID and anorexia are very different. But what happens with anorexia, I think you know about the autistic program, because you've just explained you have to introduce the food again and again, and you know, it's hard work. With anorexia, as the child becomes better nourished, their anorexic cognitions diminish. So actually, you think the more I feed them and the more weight they put on, the more resistant they will be. But actually it's the opposite. As they gain weight, they're less resistant. And actually they begin to enjoy food, or to say, I feel hungry, or I used to love chocolate, oh, so now I can have chocolate. So it's counterintuitive. You think it's going to be harder as you go along. It's actually easier as you go along to feed them. And sometimes, of course, they overeat. So they can overeat, and sometimes anorexia can shift to bulimia, and vice versa, of course.
Probably, we are talking about eating disorders, but there are young children, little children,
Yes.
who would show signs of, we take it as being picky eaters,
Yes.
but sometimes it's part of their normal growth.
Yes.
So a child wouldn't like a specific type of food,
Yes.
especially during complementary feeding, and maybe he's intolerant, but we don't know yet.
Exactly.
And I think in that case, yes, we offer the food up to maybe 15 times every now and then, and with little amounts so that they don't feel overwhelmed and they
Absolutely.
don't want to eat it.
Absolutely.
So we have to consider as well that the children who are not ill,
Absolutely.
and the way we offer them food, it makes a difference.
Absolutely. I completely agree.
Especially milk products with maybe intolerance.
Yes.
maybe allergy.
So I didn't mention, but perhaps it goes without saying, that we have to exclude organic explanations for the problem. So, you know, we want...
It's multidisciplinary.
It's multidisciplinary, and we want the physician, the paediatrician, to exclude diabetes or celiac disease or whatever it might be. And then I agree, it's developmentally normal, so we don't jump to intervene in these cases. I very rarely see children below the age of about 8. They do end up maybe in other services. I'm not saying it's not a problem, but you know, I see them where they're failing to grow and failing to function, and they have delayed puberty or other symptoms, and where there's, you know, clearly established pathology there, but not all of it is pathological. I completely agree.
Yes. Sometimes we face this problem with the baby under formula. If the baby take a formula, no breastfeeding.
Yes.
We face some problem in acceptance and preference of food because
Yes.
we have the same food and the same taste for 6 months.
Yeah.
And then start to eat. But
Yes.
this is not occurring mostly with the breastfeeding.
Yes.
Because you know breastfeeding have the flavor of food of the mother.
Yeah.
We face some of this problem.
Yes,
in our
yes,
workplace,
yes.
But we refer now to the
Yeah.
behavior.
Yeah. And we were saying earlier, weren't we, that you also have to exclude, you know, you have to look at swallowing reflex,
Yes.
and do speech and language assessments of, you know, organic, physical,
We use
explainable factors before you decide it's psychological. Yeah. Any other comments or questions? Thank you very much for your attendance. If anyone wants my slides or wants me to answer any question, I'm very happy to do my